Morning, everyone. Thanks so much for joining us today for our session from the Academy of Medicine, Engineering, and Science of Texas on COVID-19. Today's session will focus on health disparities and is part of our Forward Texas series that is focused on sharing the science behind the pandemic with a focus on research and impacts in Texas, and really looking for opportunities to move forward during this crisis. We're really looking forward to hearing from our scientists today and what they have to say. And very briefly, before we get started, I'd just like to go a little over the schedule briefly. We're going to have some remarks from our moderator to begin with, and then we'll hear from our speakers. And the speaking order today, we'll first hear from Dr. Georges Benjamin from the American Public Health Association. Then we'll hear from Dr. Keonta Moore from Rice University, and then from Dr. Jewel Mullen from Dell Medical School at the University of Texas at Austin. We're gonna have a Q&A during the second half of the session today, and the best way for you to submit your questions is through the Q&A box on Zoom. If you have a question that's very specific to one of the presenters, they may type the answer to your question, but we'd really welcome your questions and thoughts. So please use that Q&A box, and when we get to the second half of the session, we'll have some group Q&A with the speakers today. With that, I'd like to introduce our moderator for the session, Dr. Amelie G. Ramirez. She is a member of the National Academy of Medicine and the chair and professor of the Department of Population Health Sciences at UT Health San Antonio. And she's also very near and dear to us at TAMEST because she is our board president. Very glad you could be here today, and Dr. Ramirez, will turn it over to you. Thank you.
Thank you so much, Terrence. Really appreciate all that you do for TAMEST. So thank you so much. And thank you to all of those who are listening in today. We thank you for your attention. This is an issue that's very close to my heart in terms of the health disparities that we're seeing that are being caused by COVID-19. And I want to thank our panelists for making time to be available to us today. So thank you so much. Before we begin our session, I'd like to tell you a little bit about our organization. TAMEST is a statewide group that fosters collaboration and advances in research, innovation, and business in Texas. We're composed of more than 300 Texas-based members of the 3 national academies: the National Academy of Medicine, the National Academy of Engineering, and the National Academy of Sciences, in addition to the Royal Society and our state's 11 Nobel laureates. We are supported by our 18 academic member institutions and want to recognize them today for their ongoing contributions to our research community. Since the beginning of this pandemic, TAMEST has been convening experts and the greater scientific community to provide evidence-based information on COVID-19 and to foster collaborations to help combat it. Today's session will address disparate impacts of COVID-19 and other diseases. While COVID-19 is a new disease, the inequities that we're seeing as a result are nothing new. Today, we are witnessing social and health inequalities that have been systemic and part of our society for centuries. COVID-19 has just put a spotlight on these inequities that have been occurring, and you'll hear more about that today. Our underserved communities are at greater risk of contracting COVID-19 and other diseases. When they contract these diseases, they also face challenges in receiving care and see more severe impacts from the infection. Latinos, African Americans, Native Americans in the United States have been hospitalized due to COVID-19 at 4 to 5 times the rate of white Americans, according to the Centers for Disease Control and Prevention. For those under the age of 65, CDC's data shows that COVID-19's toll is twice among our communities of color. During this session, we'll discuss how COVID-19 pandemic has highlighted the racial disparities in our health system and explore opportunities to advance health equity during this crisis. We've brought together 3 leading researchers on health disparities to hear from today, and we will be taking a look at this issue from a variety of perspectives. Our first speaker will offer us a national perspective on the disparate impacts of COVID-19, chronic conditions, and other diseases. I am pleased to introduce a friend and colleague, Dr. Georges C. Benjamin. He's the Executive Director of the American Public Health Association. Dr. Benjamin is known as one of the nation's most influential physician leaders because he speaks passionately and eloquently about the health issues having the most impact on our nation today. From his firsthand experience as a physician, he knows what happens when preventive care is not available and when the healthy choice is not the easy choice. As an executive director of the American Public Health Association since 2002, he is leading the association's push to make America the healthiest nation in one generation. Dr. Benjamin is a graduate of the Illinois Institute of Technology and the University of Illinois College of Medicine. He is board certified in internal medicine and a fellow in the American College of Physicians, a fellow in the National Academy of Public Administration, a fellow emeritus of the American College of Emergency Physicians, and an honorary fellow of the Royal Society of Public Health. And he's a member of the National Academy of Medicine. Dr. Benjamin, it's a delight to have you here today. Thank you so much. Dr. Benjamin?
Listen, thank you, Dr. Maris, for allowing me to be here with you today. So let me just try to give a bit of the national perspective and why I think we're seeing this. So if you can go to the next slide. Obviously, as I call it, the great pandemic is engulfed pretty much the whole world. There's very few nations that are not reporting cases of this disease. And then probably in most cases, those are just the fact that they're not reporting. To date, we have over 4.3 million cases in the United States. And actually, as of today, we've broached 150,000 deaths. Next slide. I think the best way to look at this disparity is to look at hospitalizations. And as Dr. Ramirez pointed out, there's almost 3 to 4 times difference for the African Americans and Hispanics. I also want to bring your attention to the Native American bucket there, where that disparity is even worse compared with non-Hispanic whites. This is a central challenge. We know that we already have these disparities in a range of other chronic diseases. I don't think anybody was surprised that we would have some disparities in COVID. I do think most of us were surprised at the magnitude of these disparities from this disease. Next slide. And when you think about it, there are probably 3 major reasons why you're seeing these disparities. Number 1, exposure. Obviously, there are many people in the minority communities are in public-facing occupations or diseases or occupations at risk. So, you know, if you're a bus driver or a grocery store clerk, or you work at a meatpacking plant or a poultry operation, you're much more likely to have to go to work. You're considered what we call essential employees. And so many of those folks, particularly early on, were exposed to the disease. There's a fair amount of issue around delaying sheltering in place. A lot of that was because of misunderstandings about the relative risks of this disease. I'm going to talk about that when I talk about misinformation. And then the protests probably played a role, although most of the protests now are multiracial. So there really isn't a disparity there. But for many people of color, they've decided they needed to protest as a matter of recognizing the relative risks from police violence versus the relative risk for the disease. So I just point that out as an exposure. And susceptibility. Obviously, there's prevalence of chronic diseases. The big ones are heart disease, lung disease, diabetes, and hypertension seems to play a role. And I think the more important thing for communities of color is that we see these chronic diseases at much younger ages. So while many of us are thinking, yeah, chronic disease, age 65 and older, we're seeing a lot of these diseases in communities of color at a much younger age because primarily the prevalence of diseases and the chronic diseases that put them at greater risk, should they be infected to get sicker, occur in these chronic diseases. And of course, a range of social determinants, the lack of adequate paid sick leave, poverty, and the fact that many people, when they go home, they're not able to effectively isolate or quarantine at home because of their housing situation. Next slide. There are issues around profiling. I got to tell you that as an African-American man, I think very carefully about where I wear my mask. I always wear my mask when I'm out. But it is an issue about masking while Black. We have seen situations where African-American men have been profiled simply because they're wearing a mask in a store. There's a famous situation in Illinois store where 2 African-American men were escorted out by the guard because they're wearing face masks. And they were purposely profiled to be pushed out of that store. Next slide. And I talked about the information problem, particularly around what we call the infodemic, which is a rash of misinformation and disinformation. Some of that has resulted in helping people feel they're devalued. Some of it's about issues around word of mouth. Early on, there was concerns about and beliefs that African Americans were immune from this. That resulted in delay in a lot of African Americans protecting themselves. A lot of disinformation by foreign influences. This poster you see here is fascinating. I want to bring your attention to the CDC logo and the World Health Organization logo at the bottom, and that this says that if you get COVID, you should hang out in a synagogue, you should go to public places, you should go to low-income communities. The intent was to obviously say that if you had COVID, you should really infect others. Clearly just disinformation, but we've seen this kind of information going out, stuff on social media, flyers that are being handed out in communities of color saying don't get tested. Whenever the vaccine shows up, you should not get vaccinated. So there's a lot of this issue that we've seen. We've even seen artists, some of our influencers in the media, giving lots of bad information out there. And quite frankly, some of our political leaders who are giving misinformation. And just yesterday, many of us saw that that press conference of alleged press conference of a group of physicians who are giving bad information about hydroxychloroquine and the wearing of masks. Next slide. And we know that testing has been a challenge. Granted, testing has been a challenge throughout this outbreak. We really still don't have an adequate number of tests going on. And of course, the fact that we are now also have throughput times in terms of turnaround time for tests, which is a big problem. But early on, for sure, a lot of these testing facilities were not in places where minority communities were had. We had drive-through testing. If you didn't have a car, that wasn't easily accessible to you. We had lots of long lines, and the visit times were not often convenient for people who did shift work. There was a gateway provider requirement. Go to your doctor to get a test. Well, if you didn't have a relationship with the primary care physician, particularly in those states that have not expanded healthcare coverage, disproportionately, a lot of minorities have been disenfranchised, including particularly Hispanics, who have the largest number of uninsured, followed by African Americans in our country. And then of course the cost. Yeah, the federal government says the test is free, but going to the doctor isn't necessarily free. And so there's always a cost to getting this care unless you're going to only a testing facility that is designed only to do the test. And that continues to be a problem. Next slide. Next slide. Okay. And to ensure therapeutic equity, we need to make sure that we address access to vaccines, antiviral agents, and some of the new therapies. People are very much concerned about us having adequate access to these things as we go forward. And we can talk about that in the Q&A period. Next slide. So as I close out, one of my recommendations, obviously, I think we need to depoliticize this COVID-19 response. I also think we need to demilitarize this response to protests. It's creating a real problem with exposures. We need to promote non-pharmacological interventions, masking, physical distancing, and hand hygiene. We need to think about a more appropriate phase reopening that's being data-driven, realizing that we may have to reclose in a lot of settings. We need to make sure we have equitable testing and contact tracing, culturally competent health education, and equal access to vaccines and therapeutics. Thank you.
Thank you so much, Dr. Benjamin. You know, you've raised some very important facts in terms of some of the social determinants that were already out there, issues with poverty, lack of health insurance, and so forth that is impacting our communities of color. And just to, you know, to reiterate the personal impact of this that is having not only on individuals but families. Here in San Antonio, we had a situation where the father was working in a meatpacking company and living in a multi-generational home, you know, so came back infected. The grandfather of the family was also impacted, and both of them passed away within days of each other. And these are real lives. I mean, they, you know, our communities are saying they have to go on to work even if they have some symptoms because they're concerned of losing their job. So there's just so many things that we need to address. And then from the vaccine perspective, you know, is the vaccine being tested on all our communities, you know, so that we make sure we have an effective vaccine. So thank you, as you, and I agree, well, more questions will come up in the Q&A. So thank you so much. Our next speaker is Dr. Keonta Moore. She is a fellow in child health policy at the Baker Institute for Public Policy at Rice.
Dr. Ramirez, we can't hear you.
I'm sorry, Dr. Ramirez, you've been temporarily muted. There you go.
Okay, I'm sorry. I'll start again. Our next speaker is Dr. Keonta Moore. She is a fellow in child health policy at the Baker Institute for Public Policy at Rice University. Her research focuses on developing empirically informed policies to advance the health of children. Moore utilizes mixed methodologies, including community-based participatory research and surveys to gain insight into the health needs of communities and to develop data-driven and tailored health policy recommendations. Moreover, she helps funders and community stakeholders to develop strategies to support an equitable future for children and their communities. She received her MD degree from Baylor College of Medicine, a JD from the University of Houston Law Center, and a bachelor's in art in sociology from Cornell University. Please help me welcome Dr. Keonta Moore.
There we go. Thank you very much. I appreciate it. So you actually gave me a good segue. Today I'm going to talk about the impact of COVID on low-income women with children, as we know that income inequality significantly contributes to health disparities. Next slide. So women in the labor market. Women with children comprise a significant portion of the labor market, and approximately half, as you can see in this chart, are the breadwinners of their household. A breadwinner is a mother, is defined as someone who is either the head of the household, meaning they're the only income earner, or the woman earns at least 40% of the couple's joint earnings. When you think about racial disparities, you see that 74% of Black women are the breadwinners for their home. Next slide. So interestingly, COVID created this division in the labor market, particularly in low-wage jobs, and each have their own challenges. So we decided that there was something called essential employees, and those are folks who work at grocery stores, healthcare workers, such as medical assistants, LVNs. They will continue to earn wages because their industry is now of high demand. However, there's going to be challenges with that as women with children, again, they comprise a significant portion of the workforce, are now having to figure out about childcare for their young children or distance learning for their school-age children. There's also an increase in expenses and utility bills and food expenses because someone is at home with the children, hopefully, and they're eating more, they're utilizing the air conditioner more. If you're in the South, you know, expenses are rising, but their wages are not. There's also the increased risk of contracting COVID. If you're on the front line, you're going to be exposed to people a lot more frequently than those who have the luxury, like myself, to work at home. Then there's also the non-essential employees. So those are folks who work at retail shops, housekeeping, restaurants, and temporary work. For many of the non-essential employees, they lost their income. And even though they have the unemployment benefits, it's not enough if you think about what it takes to be able to sustain a household, particularly with rising costs of food and other expenses. And with women, particularly again, Black women, 75% are the breadwinner. So her losing her job is a significant cut for that household. And we know that this leads to increased stress and anxiety from social isolation, particularly for single parents. And in the midst of a pandemic, you need health insurance, but with the loss of jobs and massive unemployment, many people are losing their health insurance and can't afford COBRA in order to fill the gap. Next slide. So this has a risk, not just on the parents, but also on their children. We know that parental stress negatively impacts children's development, worsening health disparities, and perpetuating generational poverty. Parental and caregiver interactions are actually the primary factor in driving brain development, either positively or negatively. And parental stress increases the risk of adverse parent-child relationships. And so as an example, this one study showed that when parents are stressed, they're more likely to perceive their child's behavior as negative. So as an example, I have a 9-year-old son and he is sort of very active and sometimes he breaks stuff. And so under normal conditions, he might break a vase or break a picture frame. And I might say, remember what mommy says about, careful hands and being more mindful of what you're doing and not playing soccer in the house, etc., and not think anything else about it. But under severe parental stress, I now might perceive his behavior as being intentional and more likely to say, you did that on purpose, you were being negligent, and more likely to engage in harsh disciplinary. Parents under stress are also less likely to cope with parenting relating difficulties. And so there's increased parental stress, again, particularly for low income single mothers who don't have the spousal or partner support. And then we know from natural literature and natural disasters that there's an increase in child abuse potential. Next slide. For school-age children, there's also an impact. So even though the first couple of years of life are most significant for brain development, where the brain is developing and forming at a rapid rate, and so injury during that time really can lead to lifelong changes. But for the school-age child, there's also additional risk. The brain is still maturing, and there's certain parts of the brain, particularly the hippocampus, that's always forming new connections. So when you think about brain plasticity and when you think about harm, not being able to be in a stimulating, engaging, supportive environment for school-age children is also very problematic. And the way the brain works is if you don't use it, you sort of lose it. And so in the hippocampus, if long periods of time without academic stimulation or information, you're going to have loss. And that's why research, not surprisingly, shows loss of reading and math gains even during a short period of the summer. The reason why I'm mentioning education is because it's such an important role in breaking generational poverty and upward economic mobility. So if we want to talk about health disparities, we also have to talk about income inequality. All right, next slide, please. So what has our federal government done to help? So I want to give them the benefit of the doubt and say that they anticipated that with many stay-at-home orders initially and folks losing their jobs, that there was going to be this issue where parents had to make a choice between going to work ill or staying home and taking care of their children, but not being able to put food on the table. And so the Families First Coronavirus Response Act was supposed to address some of these issues. It created 3 provisions. One, emergency paid sick leave that gave families 2 weeks of paid sick time that the employers would be reimbursed for if they were sick, or 2/3 of their salary if they just needed to stay home because they didn't have childcare. The Expanded Family Medical Leave Act did the same thing. So it provided an additional 10 weeks if you were ill, or 2/3 of pay if for 3 months you couldn't, or for those 10 weeks you didn't have childcare. That is really important. The problem and the disproportionate impact that this bill had on low-income workers is that for many of the essential workers, this bill actually doesn't apply, because they put in an exception for businesses that have 500 or 500 or more employees, which is essentially every major grocery store. That's your big retailers, your Walmarts, your Targets. So unless the private corporation makes a decision to still offer these benefits to their employee, but they won't be reimbursed by the federal government, then these families are not included in that. So when you go to the grocery store, those workers are having to make really difficult choices to be able to serve you. So that concludes my portion, and I hope to be able to have a robust discussion about this in the question and answer. Thank you.
Thank you so much, Dr. Moore. Those are just some really critical facts in terms of the economic downturn that we're going to be suffering, and the impact that it's going to have on our communities of color is really, going to be devastating, and we need to come up with solutions of how we can help our families. So thank you so much. Our next speaker is Dr. Jewel Mullen. She's the Associate Dean for Health Equity and Associate Professor of Population Health and Internal Medicine at the University of Texas at Austin, the Dell Medical School. She also serves as a senior consultant for Ascension Seton to help meet the health equity goals across its system. Board certified in internal medicine, Dr. Mullen received her bachelor's degree and master's of public health from Yale University, where she also completed a postdoctoral fellowship in psychosocial epidemiology. She graduated from Mount Sinai School of Medicine, where she was elected to the Alpha Omega Alpha National Medical Honor Society, and completed her residency at the Hospital of University of Pennsylvania. She also holds a master's of public administration from Harvard's University John F. Kennedy School of Government. Dr. Mullen, we look forward to hearing from you.
Thank you. I am privileged to be here with you and want to confess that I hope to offer you something, because I look to this as an opportunity to glean a lot from you that will help me do my work at Dell Medical School, and hopefully help me be a better partner across Texas as we become even more intentional in our sustained work to care for our communities in the context of COVID, but for the long term. And because of that, what I wanted to do for my 7 minutes is to talk about building a collaborative research agenda for achieving health equity with lessons from COVID. And I'll start with just a little bit of a reference to some of my other experience from my time as the Commissioner of Public Health in Connecticut, and then working at the US Department of Health and Human Services. I'm taking this approach because I was hired 2 years to go to Dell Medical School to embed health equity across our educational, research, clinical, and community-facing missions, with the statement that no other medical school had a position just like that. I can't tell you whether or not that's true, but the reality is that Dell Medical School invested in a full-time position such as mine at the same time that we also have an assistant dean for diversity. And so I look at this as an opportunity to do my life's work, change the world, but try to change the world around me if I can't change everything in it. And to do so in a way that perhaps helps us build a health system that a medical school and healthcare providers are just part of, one that enables me to bridge medicine and public health and community for lasting well-being and optimal health for all. So what I will do is present some of what I have been intentional about in creating a health equity strategy for the medical school alongside our partners who are our community providers and our Ascension Seton. But I want to share a couple of things before that. One of which is that I, like many of us, and Dr. Ramirez already alluded to this, know that this is just our next and perhaps most recent example. This meaning the collision of COVID-19 and the racial violence that we have observed over the past several months. This is just our most recent example of health inequities, health disparities, and the urgency for societal change. What I wonder about is whether or not this will be the time when we actually move forward with greater intentionality for sustained change to advance optimal health for all and achieve health equity. Foundational to that, for me, has been understanding context and understanding much more about the system that people who experience disparities are forced to live within, as opposed to just looking at them as people with problems. Back when I was the Commissioner of Public Health in Connecticut, we were forced to think about that during the Sandy Hook shootings as we responded and thought about the trauma and challenges to future resilience of children in Sandy Hook, who in the Connecticut suburbs were thought to be unaccustomed to the kinds of gun violence that some thought children in our small urban communities were inured to because they were experienced to them all the time or far too often. So the mindset and starting out to think about building an effective behavioral health system that served all children and their well-being was one that couldn't overlook or take for granted that some kids didn't need it because they were so accustomed to adverse events that, as Dr. Moore just reminded us, have long-term impacts for students' social and emotional and economic and health well-being. Still, as commissioner, as we experienced the Ebola outbreak, we dealt with stigma in ways that were sort of reminiscent of what we're experiencing today, where almost every day my office would get called by an emergency department concerned that someone who was dark-skinned with an accent from another country must be from West Africa, even if they were from the Caribbean, or perhaps from Hartford, Connecticut, but perhaps thought to already be an individual at risk. The stigma that we thought we had learned how to address with communities then, but as we know through the attacks against members of Asian communities all around, including friends of mine who've lived in the US for decades, but have been looked at as foreigners, aliens, and spreaders of contagion. We still have a way to go in understanding how to address stigma in the context of all of this. And then the importance of understanding what people really believe instead of assuming what they will or will not do was underscored for us when I was the Principal Deputy Assistant Secretary for Health at the Department of Health and Human Services during the Zika epidemic, because we were trying to, in a culturally appropriate way, assure that women in Puerto Rico could have access to reliable, long-acting reproductive, reversible contraception if they wanted it. And people readily assumed women won't take it because of religious reasons or not taking Zika seriously, when in actually doing focus groups, what we learned was women were mostly concerned that their insurance wouldn't pay for it. So they were less pessimistic that they could get it than less receiving of it, which is the kind of thing to keep in mind as we also think about how we address communities of color as we go forward with therapeutics for COVID-19. So at Dell Medical School, where we have all arrived with some level of awareness and commitment to addressing health disparities, I've reversed to thinking about what we know and what researchers and policymakers have said for a long time. We need to address cultural competency, culturally and linguistically appropriate services. We need to diversify the workforce. We need to address quality, disaggregate data, ensure better access to quality care, to engage communities. And as the National Academy of Science and Engineering and Medicine made both value and equity cross-cutting components of quality, we've also known that we need to focus even more on outcomes, patient-reported outcomes, but sometimes, in my view, to the sacrifice of paying enough attention to quality and performance, when we need to realize that the inequities in care, the inequities actually might be rooted in processes and not just the outcomes. So at the medical school, I have advanced the health equity strategy that starts with ensuring that we have leadership engagement, understanding, and commitment. I have been advancing a strategy around aligning educational competencies and improving curriculum on race, instituting a health equity informed approach to research, developing a data-driven understanding of clinical needs. Many of those are similar to what's needed for addressing the disparities. The question I have in doing this is, so what can implementation science teach me that helps me understand whether or not we can do more than a little bit at Dell Medical School? How will we know that we will be effective? We are just establishing our metrics for this. What are the competencies? How do we define them? How do we measure them and track them through practice, not just through education? What do we do to assure that value-based care does not worsen rather than improve health disparities? And as we think about education, as we think about the impacts of children now, and we talk about diversifying a workforce to improve health and healthcare, how do we actually track what effective so-called pipeline, which I try not to say, or educational pathway programs will be for children's well-being, not just in health professions, but in professional success? And then ultimately, what does real leadership look like? What is sustained change for leadership development to get this work done that doesn't start at a level below a dean or a chancellor, have to be and require for training, competency, and sustained impact at that level as well? I hope to figure those things out along the way, and thank you for the time.
Thank you so much, Dr. Mullen. Look forward to partnering with you. Some great ideas there. And as you just said, you know, it's something that we, you know, if and when we resolve this pandemic, you know, let us not forget about these critical structural issues and policies that we need to address. I think that, you know, it's really now the time that we continue that focus. So thank you for your remarks. I appreciate it. I'd like to encourage our audience to please submit any questions that you may have in the Q&A box, and we'd be glad to respond to them. One of the first questions that we have, and I'm going to see, you can all chime in, is what role do you see that public health is playing to ensure that transportation security is secured along with housing security and employment security, as well as embedded in all stages of COVID-19 recovery planning? So very much the structural issues that we were talking about. Anybody like to go first?
Sure, this is
Okay.
George. I can try. You know, obviously a lot of us are giving advice to people as they beginning to reopen around how they can maintain safety as they commute back and forth from work, as well as in the workplace. And the truth of the matter is, the formula is pretty simple. Wear a mask, wash your hands, keep your distance. And to the extent one can do that, and then I've added to that, particularly in transportation, I talk about adding two other things. Number one, try to travel at hours where there's not as crowded. So rush hour doesn't work. And try to avoid that. The second thing is be as touchless as you can. And even though fomite transmission has not been a common way you got this infection, it certainly can occur. But if you can buy a bus pass, anything you can do, a wave or insert without having to touch or push the button as frequently as you can would be helpful. And then washing your hands before you leave. And then when you get to work or when you get to your location is very important, carrying hand sanitizer. And then finally, I think the most important is if you're sick with any of the symptoms that you think are COVID, or you just don't feel well that day, or if you have a fever, don't go to work, don't go out, stay home, take care of yourself.
Great, thank you. I think Dr. Moore wanted to add, and then Dr. Mullen.
Yeah, so I would say, Robert Wood Johnson has led the charge on thinking about a culture of health or health in all policies approach. And I would just add to that to say that I think we need to think about a health equity in all policies approach, because when you talk about transportation and housing and employment, all those things are intricately intertwined with one another. And so when you have experts in transportation, you also need people who understand the inequities and access to transportation, and as well as the health ramifications of being able to access transportation or not having access to transportation, and how that relates to employment opportunities. So in Houston, if you don't have a car, that drastically limits your ability to work, because our bus lines, our public transportation system is not very good. And so it limits the opportunities that you would realistically go after because you're limited by transportation. And so I think we need a health equity approach in all of these sectors. And we have a great opportunity because along, with COVID recovery planning, there's dollars now attached to that. And so for a very long time, public health has been underfunded or unfunded work. And so now we have an opportunity that there's a greater recognition of the importance of public health, and there's dollars that are now being assigned to be able to think carefully about these things. If we have the right people at the table, I think we could do something extraordinary for our country.
Thank you. Dr. Mullen?
Yes, so what I was going to add that's somewhat related to what Dr. Moore just said is that as we've thought about dialing open or close the economy in Austin, two things and increasing access to testing, we've had to think about transportation in terms of needing it to move people so that they can still get to work. And we've also need to think about it in terms of moving services to get those services to people. Because we also, as people proudly set up drive-through testing, for example, had to realize people some couldn't drive through, some couldn't walk through. So that, once again, that coordination across city or county governments, so that there's the health and all policies, but there's also to honor the work of my non-traditional public health community partners. I also know they do a lot that might not be called public health, that is very much serving public health and well-being. And that collaboration is so key.
Great. Thank you very much. We're hearing a lot about the vaccine. In your mind, how can we ensure that the vaccine is going to be made accessible in an equitable way to all our communities of color? Would anybody like to say anything about that?
So let me just contribute before I not answer that I was honored to be asked to join the recently formed Committee on Equitable Vaccine Allocation at the National Academy of Science, Engineering, and Medicine. And that's part of what we're tasked to do. While I can't talk about our specific work, I know that just the creation of that body reflects the importance of the issue. And perhaps we can send the notice of the public meetings when they will be available so that people who are interested can also log on and join those.
Great, thank you.
Yeah, it's clear that we have to do a bunch of things. So first of all, we have to deal with this enormous amount of misinformation and distrust. The most important thing I think right now is making sure that we get enough communities of color, people from communities of color involved in the vaccine research studies that are going on right now. I think that's the most important thing we need to do right now. Because once you get someone into the vaccine studies, we can then say, yep, there were enough people here that we can be sure about what its impact will be on communities of color. We can also begin getting some verifiers, and people can say, yep, I took the vaccine, it didn't make me sick, and I'm okay, and it protected me. So you need that first. Secondly, we do need to begin communicating right now in a culturally competent way to communities of color to try to make sure that people understand what a vaccine is, what it does, and what it doesn't do, okay? why you might have to take more than one shot. Preparing people for the fact this may turn out to be like the flu, a seasonal vaccine. So we need to do a lot of education in the community right now to make sure people understand everything from what a vaccine is, maybe even what the disease is, and how this works. And that's long before we start talking about how we get the shot. And then I think personally we need to think more about how do we give this shot in a way that people more at risk get it. Now, I say that because there's been a lot of debate and discussion about should it be given preferentially to communities of color because they're people of color. And my issue is it should be given to people who have the highest risk regardless of their color. Now, understanding that will give it differentially to people of color because they're at a higher risk. But if you stigmatize people based on race, then we're making the same mistake that we've made many, many times in the past. And we need to think about it because, you know, I can telework, but the person who is picking up my trash can't. And the person that picks up my trash, all other things being equal, probably needs a vaccine more than I do. And I can wait.
I'll just add very quickly that I think part of this does relate to structural racism, and that if we think about any issue of equity, whether it be access to healthcare, I know there's some questions about access to health insurance, access, you know, in any way, it really has to do with, we have a history in this country that has systematically advantaged certain groups over other groups. And so in order to any of these issues, you really need to be able to share power and resources with people from those communities. And that relates to who are you hiring? Who is the director? Who are, you know, the researchers who are conducting the vaccine research? Is there a diversity of representation in that research team? You know, we need to be asking those questions because it is not, I would say, a figment of imagination for communities of color to not trust the medical institution. Harriet, I think her name's Harriet Washington, wrote a book called Medical Apartheid, and it lays out from history all the way up into the late 90s, you know, the mistreatment of people of color in research studies. So it's not wacky or insane for people of color to be skeptical, to be, you know, involved in a vaccine trial where you're testing safety, right? Like, you know, so I think we really need to emphasize that it's important that the folks who are leading this charge, that there's a diverse representation of disadvantaged communities in decision-making roles.
Great, thank you. And it's my understanding right now that the vaccine development is only for adults. What are your thoughts about our children? I know, for example, in the Latino community, CDC says that our children between the ages of 0 and 17 make up almost 50% of the COVID cases. So what are we doing to kind of protect our children?
Well, I'll lead off with that because my research focus is for children. You know, I think that the American Academy of Pediatrics has basically issued a statement. And when they, you know, weighed the risk and some of those things that I talked about in my presentation around child development, around the lifelong impact of adverse experiences, around parental stress, the Academy came out and said, you know, we think schools should reopen. And so, you know, again, different jurisdictions are taking different approaches. You know, locally, our school districts have a phased approach. There's a variety of different opinions about that. I don't know that I have the answer, but I will say that, you know, some of the reasons for thinking that children are at lower risk is because when you look around the countries, at other countries, the rates of transmission of the virus is very low for children. And so I think the reason why people aren't talking about vaccinations for children and aren't talking about safety measures for children is because I think we sort of accepted that the risk for children is very low. I think the things that we're most worried about are children transmitting the virus to populations of risk. And I think even in some of the conversations around reopening schools, it's less about whether the children are going to get infected for their own safety, but it's more about, are they going to be little vectors that then infect the teachers and then infect the community members? And so I think that's why you don't really hear a lot about safety when it comes to the COVID virus.
And I think we're following a normal pattern. We do adults first. We make sure it's safe and effective in adults because they get to say yes or no. And then we go back and we look at children. And I suspect they will start with older children and then move down to younger children, just as a matter of course. And at some point, while they would certainly want women in this study, I don't know this, but I'm going to assume that they're leaving out pregnant women or anyone who might want to be pregnant during the time period of the study. And then at some point, they'll then add pregnant women to the study. So that's kind of how we've always done it from a safety perspective. And I suspect we will do that. Also remember, these are very different vaccines. These vaccines are been developed using really new and innovative techniques that most of us think should be work and most of us think should be safe and effective, but they are new. And so you want to be very, very careful when you introduce any new product, particularly new therapeutic like this, into the population.
One other thing we should do for children is get them caught up on all of the routine immunizations that they may have been missing over the past several months. There's such a concern about that, the loss of, people being on schedule, that, as we figure out how to get children caught up and then remember to get them, as they catch up, get them and their parents ready for flu season, and that those would go a long way, those two measures.
I wanted to ask the panel a question. There's lots of confusion with regards to health equity and having equitable access. So would anybody like to help clarify that?
So fundamentally, equity, fairness, justice, in this case, health equity, in the shorthand, I could say optimal health for all, assuring that everyone has the opportunity to be as healthy as possible with a particular focus on attending to individual and populations who have over time experienced the most inequitable, unfair treatment because of race, gender, geography, ability status, sexual orientation, etc. So that's the basic concept of what health equity is. Equity in access to care then gets to what's fair and just around access, people's ability to get medical care, which, if you think about the definition of health equity, if you don't have that access to care, it's going to be much harder for you or a system to be an equitable one. So equity and access to care, I can pass off to someone else, but that really means that your payer status, all those other characteristics that I mentioned, where you were born, whether or not you were documented, those characteristics should not influence whether or not you should get access to care and to quality care. Does anybody want to add to my long answer?
Yeah, we ought to, you know, this is real simple. We ought to treat each other the way we want to be treated ourselves. And the truth of the matter is, in all my many years of practicing medicine, and I know that my other two colleagues here have had the same experience, everybody talks a good game about access to care, about who should get it, and they should take care of themselves until they get sick. Now, everybody wants exactly the same care as everybody else, and they want everything you can possibly do to save them and prevent them from getting disease. And so if we're going to behave that way when people get sick, we ought to behave that way before people get sick. Pure and simple.
Thank you. Well, we're nearing the bewitching hour of our webinar. We certainly could use a lot more time. I just had one question that I'd like each of you to just take a minute to answer if you can. But my last question would be, what one action item would you prioritize as the next step as a nation to help us reduce our structural racism? I know there's many, but which one would you prioritize?
Well, you mean in terms of the COVID?
Mm-hmm.
Yeah, for me, it's testing. It's the public health issue. Testing, contact tracing is the key to getting our hands around this. And I would personally focus a lot on that, because we don't go to school, we don't get to do anything else without it.
Dr. Mullen?
With regard to COVID, I probably would float it back up again, since you asked about structural racism, and to continue the conversation to get people to acknowledge that it exists. I understand that, I understand the testing is huge. I also, if I go back to why I love my job and why I need to assess what I'm doing, is I want to know what's going to stick. And part of what's going to stick is moving us to stop asking us to define racism, measure racism, and prove that it impacts health, to actually doing something about it, and not feel as if we have to convince everyone before we do.
Thank you. Dr. Moore?
I would say that two things. We need to stop creating policies that continue to perpetuate structural racism. So the example I gave of the Families First Coronavirus Act, it excluded the very employees who are at the front line and who are having to make the decision between going to work so that they can put food on the table, or staying home with their children because there's a need there or because they're sick. So number one is stop creating bad policy, is number one. Number two is look at existing policy and evaluate the unanticipated consequences of existing policies that have continued to perpetuate disparities, and fix those, close the gap. You know, we have an opportunity, everyone listening here, you should be calling your policymakers about this gap. There's CARES 2 that's coming up. We should be saying, hey, in CARES 2, we want you to close this gap. We want to make sure that when I go to the grocery store, the person who's bagging my groceries didn't have to make that choice. So so structural racism by its very nature is embedded in the systems and policies. And so if we want to address those things, let's stop creating bad policies, and the policies that we think are working okay, let's evaluate the unanticipated consequences of those policies.
Great. Thank you so much. You all have just done an amazing job. I really, really appreciate it. And I would like to just add that we make sure that in the future, our communities of colors are part of those committees that are helping design the policy, and that we have strict outcomes as well, that we have some measurable goals that we want to see change. So thank you so very much. And I'd like to take it back to Terrence, who will close us out. Thank you all for your time. I can't thank you enough for being here today.
Thank you, Dr. Ramirez, for moderating the session today, and thank you, Dr. Benjamin and Dr. Moore and Dr. Mullen again for sharing the science with us. This was a very informative session, and I hope we'll have another chance to address this topic in our future sessions. If there are questions that we didn't have time to get to today, we can email those to our speakers after the session, and hopefully they can provide their responses via email, and we'll post those on our website. Each of you will receive a follow-up email with video of this session, as well as links to the slides. And we're also going to include an invite for our next session in this series, which will focus on the impacts of COVID-19 on our higher education system in Texas. This is going to be on Wednesday, August 26th. It's going to be a 90-minute session. We have 5 speakers, including 2 chancellors of university systems, 1 university president, 1 vice president for research, and 1 provost. So this will be a very robust session, and we're going to look at both kind of the immediate impacts that are being felt in our higher education system in the state, as well as what we can expect in the long term from COVID-19 in the way of impacts on higher ed in Texas. Each of you will receive a survey at the end of this session that will give you an opportunity to provide some feedback about what your experience was like today, as well as an opportunity to suggest additional topics that TAMEST should cover in the future. Again, we're really grateful that each of you joined us today and that we could share the science with you. We want to thank again our speakers and our moderator, Dr. Ramirez, and also thank our moderator, Dr. Ramirez, for all she does for TAMEST and for her leadership of our organization. That will conclude our session today, and we hope all of you will be well and stay safe.